Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/kba. This activity is supported by an educational grant from AstraZeneca Pharmaceuticals.
Hello, I'm Dr. Misty Shields from Indiana University School of Medicine here in Indianapolis, Indiana. Welcome to this activity, the emerging nuances of extensive stage small cell lung cancer treatment, individualizing care in the immunotherapy era. Joining me today in the discussion is my dear friend and esteemed colleague, Dr. Jonathan Goldman from the David Geffen School of Medicine at UCLA in Los Angeles, California. Welcome.
Thanks very much, Misty. It's a pleasure to be here.
Before we begin, I'd like you to consider this. Does the management of a rare but aggressive cancer like small cell lung cancer require a different kind of clinical preparedness than a common one? Today, we'll build on the case for why the answer is a resounding yes. The annual incidence of small cell lung cancer has fortunately steadily declined since 2000 to 2020. This is due to the reduced smoking rates across the U.S. However, survival remains largely unchanged due to the aggressive biology of small cell lung cancer, usually due to the late diagnosis, limited treatment, and targeted therapy options historically, high recurrence rates, and misconceptions regarding available treatments that we know as nihilism. What you can see here is that small cell lung cancer makes up about 10 to 20% of all lung cancers, about 5 in every 100,000 patients, with the majority being extensive stage around 70% and the minority being limited stage around 30%. And so really, because of the rarity of small cell and low case volumes, providers may have a hard time staying up to date on recent advances. There are many misconceptions on small cell lung cancer, that this only affects smokers, which is not true, that a cough is always present, or individuals who are older are the ones that are affected. In fact, many of my patients in my clinic have young onset small cell lung cancer, less than 50 years of age. This can lead to ignoring symptoms, delayed diagnosis, and delays in screening, which can help save patients who are high risk for lung cancer. So, Jonathan, can you tell us a little bit about what the survival for patients impacted by small cell looked like before the immunotherapy era?
I echo everything that you said. For several decades, we had real difficulty improving our care from initial chemotherapy. It is often a rapidly responsive type of cancer, but then becomes recurrent and more aggressive. This led to low survival rates. We consider limited stage small cell lung cancer one where we're going to treat with chemo and radiation. And even in this case, we had only a 30% 5-year survival. In the more common extensive stage small cell lung cancer, the long-term survival was very, very rare, under 5%. And this held true, unfortunately, for quite a number of years until recently. We think about staging for small cell lung cancer in two ways. We talked about extensive stage and limited stage. We also have a more detailed staging and what many people think about in cancer staging, stage 1 through 4. And this does show that the smallest tumors, stage 1A1, do have a better prognosis. Misty, in the current era where we use first-line immunotherapy, what is median overall survival looking like for extensive stage small cell lung cancer?
Thank you, Jonathan. Yeah, the impact of immunotherapy really was practice changing for patients with small cell lung cancer who were diagnosed with extensive stage. So we saw the studies with Empower 133 and Caspian in 2018 and 2019 demonstrating an improvement in survival for patients with the addition of anti-PD-L1 therapy, improving the magnitude of benefit really here for around 2 to 3 months as a median. But really seeing that tail of the curve that we had these long-term patients who are surviving really in remission or maybe even cured of their small cell at the 5-year mark. We saw the Umbrella A extension study, 12% survival, an increase of about 10% from what we had seen historically with extensive stage small cell lung cancer. A huge victory for some patients, again, really showing that the immunotherapy era was meaningful for a subset of patients diagnosed with small cell lung cancer. Here is a challenge question. Jonathan, what do you think about the 2026 National Comprehensive Cancer Network guidelines for the recommendation and management of patients diagnosed with extensive stage small cell lung cancer?
The NCCN guidelines do give us a very helpful pathway to follow when we initially evaluate our patients. In a patient with extensive stage disease, we're going to want to very quickly evaluate the patient's status, including the possible presence of brain metastases, their performance status, and underlying comorbidities. Unlike many other solid tumors, even a very ill patient should be considered for aggressive systemic therapy. That's because we see such a rapid response. In a patient that their poor performance status is due to the small cell lung cancer, we often see a patient with dramatic symptomatic improvement within a few days or a week. So, unfortunately, a lot of these patients are diagnosed in the hospital due to the rapid onset of symptoms. Even a patient that's in the intensive care unit, sometimes even intubated, should be considered for chemotherapy, ideally chemoimmunotherapy. And we may see that patient be able to leave the hospital within a week. The factors that we consider: performance status. Um, we also look at underlying diseases. Some rheumatologic diseases may make a patient ineligible for immunotherapy. And that should be carefully considered. We also require careful management of brain metastases. Unlike in the past, we do know that we do get benefit from our systemic regimen. So a patient with small asymptomatic brain metastases, we're often deciding to start with systemic therapy alone and get a close follow-up, perhaps 6 weeks later, to make sure that the brain metastases are shrinking and under control. There are, on the other side of the coin, patients with symptomatic brain lesions that requires rapid management, often steroids, sometimes radiation, as well as the systemic therapy. Furthermore, the NCCN guidelines direct us to the appropriate first-line options. They are going to be platinum, etoposide, carboplatin, and cisplatin are both considered reasonable options. I think most move to carboplatin in this setting based on its improved tolerability and decreased long-term toxicity rates. The immunotherapy agent atezolizumab or durvalumab both have good data, as Misty reviewed. We then enter the maintenance phase, typically after 4 cycles of platinum etoposide. And there we continue the IO agent, atezolizumab or durvalumab. And as we'll discuss later, the addition of lurbinectedin in that maintenance phase is a worthy consideration. We then have a more complicated decision that we'll talk about more in further recordings regarding second line and beyond therapy. Really another area of dramatic advancement, most recently with the use of tarlatamab. But the research and dynamicism of this area are very exciting. After a long period of poor advances, we're really now seeing a renaissance in small cell lung cancer research. Misty, what do the 2026 guidelines recommend for first-line management for limited stage small cell lung cancer?
Thank you, Jonathan. If we look at our NCCN guidelines for limited stage, you will see that patients should receive a platinum agent along with etoposide and concurrent thoracic radiotherapy. And at the completion of this concurrent chemoradiation period, permitting no progression, was seen on scans, should be considered for durvalumab anti-PD-L1 therapy as consolidation every 4 weeks for up to 24 months, permitting again with scans, evaluation for toxicities. There's no intolerable adverse events. The patient should complete this regimen if there's no evidence of progression on imaging throughout the course. This really demonstrated a significant improvement in survival, unprecedented, improving that median overall survival to really improving for 22 months, additionally to 55 months, a historic really advancement for limited stage, the first we had seen in over 30 years, really becoming a new standard of care. There are more trials and agents in the limited stage being investigated, but what a huge breakthrough for our patients who are diagnosed with limited stage. Here is another challenge question. Thank you, Jonathan, for an insightful discussion. Now let's move on to the next session where Jonathan will review the role and impact of immunotherapy in extensive stage small cell lung cancer.
Thank you. Welcome back. We're in our next session regarding extensive stage small cell lung cancer and the impact of the addition of immunotherapy to chemotherapy. There are two main practice-changing trials in this area. The Empower 133 trial added atezolizumab to carboplatin and etoposide. The carboplatin and etoposide was given for 4 cycles, and then the patient went into maintenance, either with placebo or ongoing atezolizumab, and patients were treated until progression. The progression-free survival curve does show, interestingly, there's little difference during the initial component of therapy during chemotherapy, but in the maintenance phase, that's where the lines do start to separate. And there is this tail of the curve that Dr. Shields referenced, and we think that's a really important part of the benefit from immunotherapy. This did lead to an overall survival benefit of about 2 months. And again, this really the curves separate after about 6 months and then are convincingly separated through beyond 2 years. And very excitingly, this does seem to benefit all groups of patients. But some of the biomarkers that were considered, such as mutation burden, did not end up being predictive of benefit, but there does seem to be a consistent benefit across the subgroups evaluated. Very importantly, the addition of immunotherapy added very little to adverse events. The toxicities are primarily due to the chemotherapy, ones that we are well accustomed with and often able to manage, and the addition of immunotherapy added little in the way of toxicity. There was not a large increase in immune-related events or paraneoplastic syndromes, as was perhaps previously worried about, but overall, just remarkably well tolerated. And in this follow-up umbrella study, we see that over 10% of patients are living significantly beyond 5 years. This is a huge increase from the historical events. Of about 1 in 10 patients may be effectively cured, certainly with long-term cancer control with the addition of immunotherapy. The second trial in this area was the Caspian trial, initially begun as a 3-arm trial with the use of a CTLA-4 drug, tremelimumab. This did not end up adding significantly to the benefit, so we'll focus on the 2 arms, the EP arm or the EP with durvalumab arm. Otherwise, these trials were designed similarly with the induction phase of chemoimmunotherapy and then a maintenance phase of immunotherapy. The Caspian trial did go up to 6 cycles, a small difference just to evaluate perhaps another previous standard of 6 cycles. But in the study arm, it was 4 cycles of chemotherapy. Again, we see that in the first 6 months of therapy, the curves are essentially overlapping, but then they separate, and they separate convincingly with 2.5, 3 month overall survival benefit. Patients living beyond a year, which was a significant milestone for us. And most importantly, we believe this tail of the curve offering, we feel for many patients, the potential for long-term disease control and survival in this 10 to 20% range of patients doing well long-term. Progression-free survival, again, looks similar to the Empower trial. These 2 trials are more similar than different and really provide a lot of confidence in the benefit of the addition of a PD-L1 inhibitor. Safety does look similar between the 2 arms, again, with very little added toxicity from the use of an immunotherapy agent. This led in close succession to the approval of either the atezolizumab or the durvalumab arm. So it began the current era of first-line therapy, platinum etoposide for 4 cycles, concurrently with immunotherapy, and then immunotherapy is continued in the maintenance phase until toxicity or progression. Here's a challenge question. In summary, we see that these two trials really ushered in a new era for the treatment of extensive stage small cell lung cancer. The addition of a PD-L1 immunotherapy agent improved outcomes with very little toxicity and began a new time of extensive and really exciting small cell lung cancer research that we'll get into in the next presentation. Welcome back. We're very excited to move on to the next section to discuss ongoing trials and new directions in extensive stage small cell lung cancer. As in many cancers, we found that moving drugs that are effective in the later line earlier can have important survival benefits. We lose about 40% of patients as we get into second line and over 60% of patients when we get to third line. So moving those drugs either into the induction or maintenance phase may have important survival benefits. So this was studied in the IMforte trial using a drug that was previously used in the later line, lurbinectedin, and moving that into the maintenance phase in combination with atezolizumab. This was a trial only for patients that had not progressed after their first line induction therapy, and patients with brain metastases were excluded. Patients that were eligible were then randomized 1-to-1 to lurbinectedin with atezolizumab or atezolizumab alone. The patients do in many ways reflect our patients that we see in the clinic, but perhaps a little bit younger. About a half were under 65 years old. More were men than female. And we see that liver metastases were in about 40%. Progression-free survival shows this really significant hazard ratio of 0.54, adding a little over 3 months in progression-free survival. And this we certainly would think of as a clinically significant improvement. Overall survival was also improved at the median by about 2.6 months, had a hazard ratio of 0.73. Toxicities are something to be aware of. Lurbinectedin does have chemotherapy-like toxicities, including low blood counts and some nausea and fatigue. The increase in adverse events is clear, but in many cases manageable. It's an important discussion for patients when they're entering this maintenance phase. We have also looked at adding other agents into the first line induction and maintenance regimens. Tarlatamab is one of the most exciting new drugs in small cell lung cancer therapy. It's a bispecific T-cell engager that attaches to tumor cells at DLL3 and brings in T cells through a CD3 binding antibody. This trial added in tarlatamab with the anti-PD-L1 in the first-line maintenance in this 303 trial that allowed patients with either atezolizumab or durvalumab as their backbone immunotherapy agent. Again, these were patients that had not progressed and then were continued on the immunotherapy with the addition of tarlatamab. These here we're not looking at a control arm. We're only looking at the arms with tarlatamab and the PD-L1 inhibitor, and this does compare very favorably to a historical control. Overall survival perhaps is even more exciting. Really, what you might consider very flat curves going out 12 months. Overall survival is a little over 80%, and even to 24 months, the majority of patients are still alive. To discuss tarlatamab in a little more detail, the safety and adverse event profile is important to consider. Like many bispecifics, we do have a cytokine release syndrome that is most evident in the first and second cycle. There's a lead-in 1 milligram dose, and a week later, step up to the 10 milligram dose. At both of those time points, cytokine release syndrome is quite prevalent in at least half of patients, often grade 1 or 2, but you may see high fevers, tachycardia, shortness of breath, and low blood pressure. and very important to monitor for these. Later toxicities include dysgeusia and constipation. There are also just some generalized lack of appetite and fatigue. The 305 trial is a randomized trial evaluating uh, further the approach that we just discussed, adding in tarlatamab to a PD-L1 agent. In this trial, it's only durvalumab that's being evaluated, again, in a randomized 1-to-1 fashion. And we'll be looking forward to those results anxiously. Here is a challenge question. Please join us at the next session. We'll be talking about some of the nuances in the choice of these regimens for extensive stage small cell lung cancer. Welcome back. We're really excited to continue our discussion about the revolution in care for small cell lung cancer. We're going to pick up on some of the points in the last session where we talked about bringing lurbinectedin and tarlatamab into earlier lines of care with some clear evidence of benefit. Lurbinectedin is a synthetic alkylating agent. It binds to the DNA's minor groove, therefore disrupting transcription and leading to apoptosis. Some of the additional mechanisms of benefit may include an immunologic activation, and that led to interest in an immunotherapy combination. Toxicities of lurbinectedin are primarily cytopenias. There is some fatigue. Otherwise, generally a well-tolerated regimen. In this randomized trial of IMforte comparing lurbinectedin with atezolizumab to monotherapy atezolizumab, we do see the increase of cytopenias and GI toxicities, but mostly low grade. In the maintenance phase, where a patient has just come off of platinum etoposide, we do think that important consideration to the timing and monitoring for perhaps worse cytopenias than you would have seen in a more second-line patient. So use of growth factor support, monitoring mid-cycle for thrombocytopenia, and management of anemia are quite important. The patient will be on immunotherapy as well, so monitoring for immunotherapy toxicities is also important, and an ongoing evaluation of the risk-benefit ratio in this maintenance setting is also an important part of discussions as you follow up with patients. We'll now move to tarlatamab. Tarlatamab is a T-cell engager. It's a bispecific that is binding to T cells via CD3 and to tumor cells via DLL3. DLL3 is a Notch ligand, and we have found that it is regulated on the significant majority of small cell lung cancer to the point that DLL3 testing was not required in order to identify patients for this therapy. The drug is bringing the T cell in close proximity to the tumor cell and likely also delivering an activating signal that leads the T cell to kill the tumor cell. Like many bispecific T cell engagers, the toxicities are primarily cytokine release syndrome. In order to discuss these toxicities, we can look at the Delphi 303 safety. This was adding tarlatamab to immunotherapy, PD-L1 agent, either atezolizumab or durvalumab in the maintenance setting, and bringing in tarlatamab in this maintenance setting. We begin with a lead-in dose of 1 milligram, and then a step-up dose a week later of 10 milligrams. This step-up design was in order to manage cytokine release syndrome, which is primarily seen at the first 2 doses, day 1 and day 8, and a little more than half of the patients with mostly grade 1 and 2 constitutional symptoms. Fever is very common. You can get tachycardia and even to the point of shortness of breath or hypoxia, although those would be rarer symptoms. Later on, in therapy, generally a well-tolerated regimen, but there can be some change in taste and decreased appetite. Constipation is also common, generally low-grade event, but are important to manage. Here is a challenge question. Thank you very much. Please join us for the next session where Dr. Shields will be reviewing some of the nuances in our choice of therapies.
In this next episode, we'll discuss the personalization of care for patients with small cell lung cancer. As you know, the treatment arsenal for extensive stage small cell lung cancer continues to expand, thankfully, and so desperately needed. But this one-size-fits-all approach is really no longer sufficient. Today, we'll be moving beyond the general landscape of small cell lung cancer to focus on critical next steps, which is personalization of care. We've discussed many of these exciting trials already in the previous episodes, but as you recall, Empower 133 and Caspian, both first-line phase 3 extensive stage small cell lung cancer trials, investigating the role of immunotherapy for patients with extensive stage small cell lung cancer in the induction and maintenance phase improved survival. This had demonstrated efficacy with this addition. But remember, the patient selection was influenced by factors such as performance status and the presence of brain metastases that had to be stable on scans. Sometimes this doesn't reflect the real world and what we see when we have a patient in clinic with us. The Adriatic data for limited stage unprecedented survival that was presented at ASCO 2024. And we know that there is toxicity with this regimen, with grade 3 and 4 adverse events, up to 24% of patients and maybe higher. So this really highlighting the need to safely assess patients' tolerance for the role of immunotherapy for consolidation in limited stage. What you'll see is that many of these studies, really with Empower 133, Caspian, and Inforte, all first-line therapies in extensive stage with the addition of immunotherapy and the addition of lurbinectedin with Inforte, what you can see is patients, regardless of age, benefited. Really, patients under 65 or over 65 really benefited with the addition of treatment, suggesting that age is really just a number and that patients should be evaluated for their fitness and making sure that they have support at home to make sure that we get them the right therapies that really matter for them. You can see ECOG performance status of 0 to 1 across all of these studies really did not impact outcomes and really tended to favor the addition of immunotherapy or the addition of maintenance strategies. So patients really do benefit. It's important we support them, adequately assess them at diagnosis to ensure the performance status for patients is accurate. And if it's due to comorbidities or disease, that matters, as we've seen in the NCCN guidelines. And patients with brain metastases and liver metastases may have worse outcomes regardless of treatment. And so it's important that we give them access to new standard of care with chemo and immunotherapy that really can help improve outcomes. And again, local modalities such as radiation and working with a multidisciplinary team is key here. But we know patients, regardless of these factors, tend to benefit with aggressive therapy. So really it's important we should identify those patients, get them on the right treatment, and not shy away from these new standard of care for patients with small cell lung cancer. So in summary, we know that patients with small cell lung cancer may have additional risk factors or comorbidities or sites of metastatic disease that could be prohibitive or even impact treatment decisions. But chemoimmunotherapy and actually immunotherapy and lurbinectedin maintenance, what we saw in the Inforte study, is beneficial to patients and helps them live longer and keep their disease at bay for longer. And so it's important that we leave these biases of age, performance status potentially at the door, because it is not beneficial for our patients. Patients do benefit, and we really should help support them and get them on the right treatment strategies. Here is a challenge question. Thank you. Let's discuss this next patient case. Meet Edward. He's a 75-year-old gentleman who has been diagnosed with extensive stage small cell lung cancer. He has an ECOG performance status of 1 and a former tobacco history of 45 pack years, but has quit several years ago. He has been previously diagnosed with hypertension, COPD, and high cholesterol, and he presented with cough, fatigue, and weight loss over the past 3 months. CT scan of the chest revealed a 4.2 centimeter left upper lobe mass and mediastinal lymph nodes, for which he underwent a bronchoscopy and biopsy revealing small cell lung cancer. Additional staging with PET CT revealed FDG-avid liver and skeletal metastases, and MRI brain, importantly, showed no evidence of CNS disease. So comprehensively, this gentleman was diagnosed with extensive stage small cell lung cancer de novo with metastatic involvement in the liver and bone. So important discussions here. What would be a first-line induction and maintenance therapy for this lovely patient? I think that this patient is 75. They have a good performance status. And what we know is that they have evidence of small cell, both pathologically, as well as evidence of disease outside of the lung with liver and skeletal metastases. Importantly, no brain metastases. So I would discuss with this patient, if in the absence of any trials at my center, I would discuss with them either chemoimmunotherapy with either anti-PD-L1 therapy, atezolizumab, or durvalumab. And at the time of maintenance, I would discuss with them also, leading up to that visit, the role of lurbinectedin after the induction of 4 cycles of chemoimmunotherapy if the patient had no progression on imaging after restaging and no evidence of any brain metastases after induction chemoimmunotherapy. As mentioned, we know that there is survival benefit with the addition of immunotherapy over platinum-based chemotherapy. And we also know there's a survival benefit with the addition of maintenance lurbinectedin in comparison to maintenance immunotherapy alone. And so the addition of lurbinectedin and atezolizumab will help the patient live longer and improve survival and outcomes. Important toxicities that we should really be watching. Again, hematologic. We want to make sure that they have good bone marrow reserve, that their counts are doing well, and that they feel good and actually feel better on therapy. This is important. We also want it to assess adequately for any autoimmune diseases to ensure that the patient does not have any contraindications for immunotherapy. And importantly, we want to make sure that there is, again, no presence of CNS disease at baseline or ever in their course, because this might not be the right strategy to add lurbinectedin that does not have good CNS penetration. In terms of supportive and preventive care strategies, what do I use in clinic? Every patient should be well supported. Patients with small cell need more support, not less. They should be referred to early palliative care. This should be integrated into their care plan. And also, I like to support my patients additionally with trilaciclib, which is a CDK4/6 inhibitor that's given during induction chemoimmunotherapy, which is given on days 1, 2, and 3 prior to each cycle of treatment as a pre-med to help prevent myelosuppression due to chemotherapy. If this patient had CNS disease, again, that would change the discussion. Are they symptomatic or not? Do they need treatment with local modalities such as radiation or steroids? Or do they even need a surgical evaluation for potentially troublesome lesions that might be urgently need to be treated or evaluated? And how would I discuss this with the patient in a meaningful shared decision-making model? Again, invite the patient to have family and friends join them for any of these decisions as they feel comfortable. Support is key. We really need to fight back on the stigma and isolation of this disease. Patients need a community like our small cell smashers to help support them. And really giving patients the information so that they can make an informed decision with all of the facts and data in a fashion that makes most sense to them so they can make the decisions along the way with multiple touch points to ensure that all of their questions and concerns are answered. I think chemoimmunotherapy is here to stay, and really that maintenance strategy with lurbinectedin, if it's the right patient, including hematologic reserve and absence of brain mets, is key. Here is a challenge question. Thank you. In this next session, we will review the latest immunotherapy advancements for limited stage disease. As we discussed in our earlier presentation, Limited stage small cell lung cancer has seen some tremendous advancements of late, but it hasn't historically always been the case. Limited stage small cell lung cancer accounts for 30% of the diagnoses, so a minority of the cases. That unfortunately, a majority of patients with limited stage will have recurrence of the disease within 5 years of their diagnosis. And so, is there a role for immunotherapy in limited stage as an adjuvant therapy after concurrent chemoradiation? Let's look at some data. Here we saw the Adriatic study, the national placebo-controlled study, where patients who had limited stage that were either deemed inoperable, stage 1 or 2, or stage 1 through 3, limited stage with an ECOG performance status of 0 to 1, who received concurrent chemoradiation and did not demonstrate progression on restaging scans, were stratified to either receive durvalumab or placebo, or the combination of durvalumab and tremelimumab, which we have not seen this unblinded data. There were 2 primary endpoints, overall survival and progression-free survival, that were evaluated with the addition of immunotherapy in the maintenance setting every 4 weeks for up to 24 months or until progression or intolerable adverse events. As you can see, the survival in the durvalumab arm was significantly improved with a hazard ratio of 0.73, a significant p-value, improving the ratio and risk for death or any cancer-related causes here with the addition of durvalumab after concurrent chemoradiation for limited stage over placebo, which was historically the standard of care for patients in the pre-immunotherapy era. You can see that patients had significant benefit regardless of age, performance status, or any other variables that we are evaluating, including the choice of platinum or the choice of radiation, whether given daily or twice daily. It's interesting to note that the patients who received carboplatin had a significant improvement over the patients who had cisplatin. Again, it wasn't designed to look at this. It does call into question our choice of platinum in the limited stage. We also see a significant improvement in progression-free survival. Here, you can see 16.6 months compared to 9.2 months with a hazard ratio of 0.76, significantly improving the control of small cell lung cancer with the addition of immunotherapy compared to placebo. In the subgroup analysis, yet again, we see that patients had stratification based on certain variables such as prior receipt of PCI, platinum-based therapies, and the radiation schedule. Important to note, the confounder of PCI may be the investigator's bias or selection of the certain patients, since it was permitted but not mandatory for all patients. There were no major upticks in the safety in the addition of durvalumab compared to placebo in the Adriatic study. No major increase in radiation or all-cause pneumonitis. We did see an increase in hypothyroidism, which would be expected with the addition of an immune checkpoint inhibitor. So what are some of the evolving therapies for limited stage small cell lung cancer? One interesting study is the Delphi 306 study looking at the role of tarlatamab, the DLL3 CD3 bispecific T-cell engager for limited stage small cell lung cancer, patients who have not progressed after concurrent chemoradiation. Again, this is an ongoing study where patients are randomized to tarlatamab compared to placebo. Important to note, this is pre-Adriatic in the design and implementation of this study. So really, we're not seeing the true control arm here of durvalumab in this study, something to note. We also know that there's the ongoing TIGOS study. So this is really an exciting study for limited stage small cell lung cancer, looking at the role of antifucosyl antibodies and immunotherapy with PD-1 inhibitors. So really stay tuned to see what this study will read out as. So key takeaways with the addition of immunotherapy in limited stage. While concurrent chemoradiation has been our standard of care for many decades, the recent data with the addition of immunotherapy, some of these other agents may be reshaping our landscape. We know that the addition of consolidated durvalumab for every 4 weeks up to 2 years is now considered the standard of care in our guidelines and has regulatory approval for patients who are eligible following concurrent chemoradiation, permitting no progression of disease. There's ongoing active research looking at how we can improve these outcomes for patients, and can we capture responses even earlier with some of these exciting agents like DLL3, CD3 bispecific T-cell engagers. Here is a challenge question. Thank you. We hope that you have enjoyed these sessions on managing patients with small cell lung cancer.
This has been an activity published by PeerVoice.